team from Australia. And welcome to week 3. So today we will be learning and discussing, as Sangeet mentioned, about the management of other symptoms besides pain, such as nausea, vomiting, dyspnea, and the psychosocial, emotional, and spiritual distress. As we all know that patients and families confronted with an advanced or terminal illnesses goes through these various symptoms, and that severely affects their quality of life. So to do the session, I would like to welcome our 3 presenters. Professor Melanie, whom you all have met last week during the pain session. Melanie will be presenting on nausea and vomiting, and she will be followed by Dr. Anil Tandon, who will present on dyspnea. And Dr. Anil Tandon is a consultant physician and the head of Department Palliative Care Services at Sir Charles Gardner Hospital in Perth. Anil has been working in palliative care since 1997, and he currently works both in a government hospital as well as in 2 towns of the Central Desert region in Western Australia. Anil volunteers with Apply, an Australian NGO dedicated to supporting the development of palliative care in the Asia-Pacific region. And as you all must have noted from his name, Anil Tandon, as many of us in Bhutan are familiar with the Indian actress Ravina Tandon, Anil is of Indian origin. His parents are from North India, although he himself was born and raised in Australia. He has worked alongside a number of palliative care services in the northeast of India in partnership with Indian colleagues over the last 13 years. And Anil is very much looking forward to this partnership with Bhutan. Thank you very much, Anil. And we are looking forward to the partnership as well. And our third presenter is Dr. Kinley Bhutti, who will be doing a case presentation today. Dr. Kinley Bhutti is a dedicated and accomplished medical professional with a diverse background. Dr. Bhutti earned her MBBS degree from Chittagong Medical College in Bangladesh. And driven by a desire to broaden her medical expertise, Dr. Bhutti undertook a Master's of Medicine in General Practice here at the Medical University in Bhutan. This postgraduate qualification equipped her with comprehensive knowledge and skills in general medicine, allowing her to make a meaningful impact on the health and well-being of her patients. Dr. Bhutti has recently come back after completing her fellowship in supportive and palliative care at the National Cancer Center in Singapore. Her experience with the fellowship has not only enriched her understanding of palliative medicine, but also instilled in her a deep sense of compassion for patients facing challenging health circumstances. Currently, Dr. Kinley Bhutti serves as a GP at the Paro District Hospital, but will be soon joining the palliative care team at the National Referral Hospital in Thimphu, which we are all looking forward to. Welcome and thank you, Dr. Kinley. And with that, I would like to hand it over to Melanie for nausea and vomiting session. Thank you.
Thank you so much, Tara, and welcome everyone to week 3. I'm going to share my screen. Have you got that? Can you see that?
Yes, ma'am. It is visible.
Lovely. Sorry, I just haven't got my presenter view yet, so there we go. All right, so nausea and vomiting. As I kick off, I'd like to just acknowledge Dr. Chian Yo, who's a Malaysian doctor who worked with us in Sydney for a year until July of last year, and she presented on nausea and vomiting, and I have developed the slides that she initially presented. So how common is nausea and vomiting? It's common across the range of patients who we see in palliative care. In advanced cancer, it's up to 68% of patients. In renal failure, 30 to 43%. heart disease 17 to 48%. And in the work that Tara did looking at palliative care needs of patients in Bhutan, of the cancer patients, 19.5% had nausea and vomiting, and 26.8% of the non-cancer patients had that prevalence of symptom. Nausea and vomiting has many causes, and today we're really going to talk about how we, from history and examination, identify the cause, and how we target our treatment specific to that cause. The cause may be disease-related, and when we're thinking about nausea and vomiting, we're really thinking about what the origin is. Is it a gut cause? So it might be gut-related, caused by gastric stasis or poor emptying of the stomach. It may be caused by bowel obstruction. Different cancer types have higher frequency of nausea and vomiting. There may be metabolic and electrolyte imbalance, which causes nausea and vomiting more commonly of a central origin, which, in other words, in the higher centres and in the chemoreceptor trigger zone. We'll talk a little bit more about that shortly. Organ failure. It may be treatment related, and we all know that anti-cancer treatments, particularly chemotherapy, can cause very severe nausea and vomiting, as can radiation, particularly when either the brain or the abdominal organs are irradiated. Opioids can cause nausea and vomiting. It's often transient. It may be short-lived and resolve after 3 to 4 days. If it doesn't resolve, then it may be that a different opioid could be tried. Central nervous system causes, raised intracranial pressure caused by cerebral metastases or primary brain cancer can cause nausea and vomiting. Importantly, anxiety and fear is a cause. It's usually something that we would only diagnose after we've excluded every other cause, but it can be a very potent cause of nausea and vomiting. And one of the things that we used to see, we don't see so often now, and I'd be interested in your experience in Bhutan, is people on their way to chemotherapy having nausea and vomiting in anticipation of the chemotherapy-induced. Vestibular causes are common and important, and we will talk about how to distinguish those from other causes. And then there's a big group that we actually don't know what the cause is, or where there are multiple causes. I hope you can see this diagram here. These are the pathways that cause vomiting, and there's a couple of reasons to point them out. One is to show the parts of the brain and body that are involved, and the other is to show you the receptors. I can imagine that the receptors are a bit hard to see, so I've blown that up on the next slide. But to show you here that this stands for the chemoreceptor trigger zone, which is in the floor of the fourth ventricle. The vestibular input that really comes from the middle ear and the vestibular centres, and the higher centres, so the brain, where we were talking about how anxiety can cause it, those centres, they all meet at the vomiting centre, and there are receptors there, which I'll show you in the next slide. There are gut causes, and they all feed back up to the vomiting centre. You can see there via the vagus nerve there, from the liver, from the gut, but also from many other organs. We all know that someone who has a heart attack may have vomiting and diaphoresis as part of their presentation. So there are receptors in the viscera and serosa of the head and neck, thorax, abdomen, and pelvis. So here I've just blown up the central centres. So the chemoreceptor trigger zone, the vestibular centres, higher centres, and vomiting centre. And you can see here that in the chemoreceptor trigger zone, we've got dopamine and serotonin receptors. In the vestibular centres, we've got histamine and acetylcholine receptors, and in the vomiting centre, we've got a combination of histamine, acetylcholine, and serotonin. So these are the receptors that our antiemetics work on, and we're always thinking to ourselves, what receptors are we trying to target as we treat nausea and vomiting? So how are we going to approach the assessment of someone with nausea and vomiting? In general, it's very similar to the principles that we applied last week when we were talking about pain. We want to identify the cause, identify the etiology, and treat reversible causes. And we want to direct the treatment at the cause. So there are symptom features that will give us an idea of what the cause is. Just excuse me one second. Okay, so just excuse me one second. I'm just going to double check I've got. Okay. So what are the different symptoms that suggest to us that the cause is different? People who have, I'm sorry, I feel like I'm missing a slide, so I do apologise. I think what I'll do is just keep talking to it, but I feel like I'm missing a slide. Apologies. We'll carry on. Let me just check that one more time. Okay. All right. So there are different symptom features that will give you an idea of what the cause is. We'll talk about those a bit later. You want to know what the background disease is, and that will give you a sense for what might be the particular cause. For instance, someone who you know has a lot of abdominal cancer, has had a bowel obstruction, like the case we talked about last week, then they're much more likely to have a gut cause. A medication history, are there medications that are going to be triggering? Are they on opioids, for instance, that may trigger nausea? In physical examination, we're wanting to do a central examination looking at whether there's any neurological disturbance, but also examining the mouth and the abdomen. We'd like to do investigations, in particular looking for things that can be causing metabolic disturbance and causes of nausea and vomiting, looking at the sodium levels, calcium levels. Hypercalcemia can cause quite severe nausea and vomiting, and actually cause constipation as well, which can exacerbate the nausea and vomiting. Glucose levels, thyroid levels, urine microbiology to see if there's a urinary tract infection, stool, and radiology. So looking at this, a CT brain if there's suspected cerebral metastases, an abdominal X-ray, particularly looking if we're concerned about the risk of obstruction, and an abdominal CT. When we're choosing the antiemetics, we're going to identify the antagonist to the possible pathway involved. We want to choose the appropriate route. It may be that someone who's got a little bit of nausea but no vomiting can choose an oral route for their antiemetic. For those who've got nausea around the clock, they will need a regular dose and as required medications. And as we're thinking about it, we'll make sure that there's no drug-drug interactions that are meaning that we're not getting the benefit from one agent as opposed to another. All right, let's carry on. So I'm going to go through the different antiemetics at this point. I have highlighted in yellow the medications that you have available on your essential medicines list. We're starting here with the dopamine antagonists, and there's many of them. And the important thing to think about between them are ones that are going to work more on the gut and ones that are going to work more centrally. So haloperidol is a medication you've got on your list for psychosis, but is commonly used in low dose in nausea and vomiting. And the reason for that is that it's very specific for the dopamine receptors in the chemoreceptor trigger zone and is excellent for central nausea. So you'd use it for opioid-induced nausea and vomiting, chemical and metabolic causes. They do have side effects. Somnolence or drowsiness is one of the side effects. We do find that in low dose, that doesn't seem to be as much of a problem. The next one is metoclopramide, and importantly, this works on both the gut via the via the dopamine and serotonin receptors, but also centrally on those same receptors. It crosses the blood-brain barrier. Domperidone is a medication that you don't have available on your list, but doesn't cross the blood-brain barrier as much, and so it can often be used for people who get some side effects. And the extrapyramidal side effects of haloperidol and metoclopramide is what they are is where people get very, very restless and they feel like they can't stay still. It's called akathisia. In very high dose, they can be much more severe symptoms than that. But we don't tend to need those very high doses because there are other options these days. In terms of second line, and I'll show you the stepwise of the order of things, there are other dopamine antagonists that actually act on a whole lot of other receptors as well. Olanzapine would be our main choice. Chlorpromazine I've put there on the list. We haven't used it in this situation for many years in Australia because we have levomepromazine, but you haven't got that on your list. Chlorpromazine is extremely sedating, so we hardly use it. Olanzapine, however, is really our a second line agent which can be used. It, as you can see, works on pretty much all the receptors that we were talking about. It works on the dopamine, histamine, and the acetylcholine receptors, so covers all the different sites when nausea occurs. There's also it will work therefore on the gut and on central and vestibular causes. They do cause drowsiness. They can cause orthostatic hypotension. They can prolong the QT interval, and particularly olanzapine can cause weight gain. So now we'll talk about all the other groups. So all those were dopamine antagonists. Histamine is a really good antihistamines are really good antiemetics, and you can pretty much choose any antihistamine you like. You have availability of promethazine, and it works on histamine as well as acetylcholine receptors. And we'll talk shortly about why, how do you pick one over another? How do you pick as a vestibular cause over a central cause? And then the serotonin antagonists, ondansetron, is available for chemotherapy-induced nausea and vomiting. It's also very useful for radiotherapy-induced nausea and vomiting. We do try and avoid it otherwise in palliative care because it can cause constipation in particular, which is a problem for many of our patients because they're on opioids. Others include dexamethasone, very good for raised intracranial pressure, malignant bowel obstruction. Benzodiazepines can work on the GABA receptors to reduce the higher centre causes of nausea and vomiting. Octreotide and glycopyrrolate are useful in malignant bowel obstruction to reduce secretions. Both those agents have that effect. Okay, so now to just go through rather than looking from the receptor to the medication, we're going to look at what different causes there might be and how they might present. So someone with gastric stasis is very likely to have symptoms related to their to the stomach not emptying. They may get early satiety. They may get, in other words, they get full quickly when they're eating. They may get nausea that starts very soon after eating. Metoclopramide, 10 milligrams 3 times a day, is the best agent in this situation because it increases gut motility. People with malignant bowel obstruction, they may present with large volume vomitus with very little nausea. And that's a signal that may well be nausea and vomiting caused by bowel obstruction. They will also have abdominal distension. If it's a high obstruction, a gastric outlet obstruction, then they may have a gastric splash and less abdominal distension. They may stop passing bowel motion and wind. And the antiemetic that's helpful for that is haloperidol, 0.5 to 1 milligram subcutaneously twice a day. It acts centrally on the chemoreceptor trigger zone. And octreotide, which can reduce gut secretions. Chemical causes will present with a sense that people get nausea, for instance, at the sight or smell of food. It may be constant nausea and isn't related to actually eating food. It can be caused by drugs or metabolic causes. And metoclopramide 10 milligrams 3 times a day is an appropriate agent for that, as is haloperidol. Increased intracranial pressure. You want to try and reduce the pressure, dexamethasone, oral or subcutaneously, plus haloperidol. So you're actually working at the mechanism there with the dexamethasone as well as the symptom with the haloperidol. Vestibular causes will present where there's an association with vertigo. It may be movement related, so that when people move their heads or move their bodies or are traveling, they may get nausea. But the real distinguishing factor is that they'll have an association with dizziness and true vertigo, where it's not lightheadedness, but actually the world. They have this sense that the world is spinning. Promethazine is an appropriate agent for that, 10 milligrams 3 times a day or 25 milligrams intravenously. Severe constipation is a very common cause of nausea, and metoclopramide is an appropriate treatment for that, plus laxatives or suppositories or enema. You will get a sense for whether or not that's the cause by taking a really good history of bowel function. It may be that someone's opened their bowels, but they had at some point in the previous few days, several days where they didn't open their bowels, and often a really good history will identify that. Hyperacidity, so a proton pump inhibitor such as omeprazole can help that, or histamine antagonists such as ranitidine 150 milligrams twice a day. As I mentioned, chemotherapy or radiotherapy is nausea related to that, can be treated with ondansetron, plus dexamethasone is often given with the chemotherapy. So in terms of the steps in that you would use in treating, step 1, as we've talked about so far, is treating the cause. And if the cause is unknown or multifactorial, then metoclopramide 10 milligrams TDS is a really good starting point, or haloperidol 0.5 to 1 milligram twice a day. And given the fact that, I'm not sure how much access you would have to haloperidol for that indication. Tara did let me know that you could access medications for an indication other than the one that it's on the essential medicines list. Step 2 would be a broad spectrum antiemetic, and in your case, olanzapine. And step 3 is a combination therapy, such as olanzapine, sorry, I apologise for this typo there, olanzapine and benzodiazepine, or olanzapine and dexamethasone. If there is nausea and vomiting in malignant bowel obstruction, octreotide around the clock, plus haloperidol. And then if it continued, you could add an anticholinergic such as glycopyrronium you have available there, or dexamethasone, which can reduce some of the tumour-related edema and reduce the actual obstruction. In terms of drug-drug interactions, I think the main one to think about is metoclopramide or a prokinetic and an antimuscarinic, such as cyclozine. The reason for that is that they counteract each other. So a prokinetic metoclopramide will increase gut motility, whereas an antimuscarinic does exactly the reverse. So there's no point in having them both at the same time. Metoclopramide and haloperidol can be used together. However, you need to be very careful for extraparameter side effects, that restlessness that I was mentioning before. In terms of non-pharmacological management, this must not be forgotten. Mouth care is really important. People who have nasty oral thrush or very dry mouth can get nauseated related to that. Diet modification, so small, frequent meals can make a big difference. And also behavioural therapies, so making sure that people are sharing a meal, for instance, can make a difference to the frequency and severity of nausea. The environment and complementary therapies, thinking of things, for instance, like ginger or aromatherapies or other things that there's evidence for in nausea and vomiting. And I think we'll finish there. Thank you so much.
Thank you very much, Melanie. This is such an important topic, and very often, even if there's no other symptoms, nausea and vomiting is almost always there in patients with advanced illness, as you mentioned, with so many different causes. It could be disease-related, treatment-related, or any other causes. So I was actually saying in the chat that maybe our doctors here in the group could tell us the dose, because I'm not very sure, to be honest. So maybe we will get to hear from them. And in the meantime, I would now like to welcome Dr. Anil. Over to you, Anil. Thank you.
Thank you, Tara. Thanks, Melanie. Sangeet, would you be able to put my presentation up and
Sure.
we'll make a start. I have to say, Tara, I was very surprised to hear you say their name, Anil Tandon. I did put in the group chat that she is my cousin. I've only met her once, though, and that was many, many years ago, so not really much of a claim to fame. So thank you, everyone. And I will be talking about the management from a palliative care perspective of dyspnea. Thank you. So in this set of 20 or so slides, I will be talking about this concept of total dyspnea, and then looking at the management from really 4 types of therapies: opioids, anxiolytics, oxygen, and non-pharmacological, non-drug measures for dyspnea. And then interspersed through that, I am just going to talk about a patient that I looked after for a period of time a few years ago, that she illustrates quite a number of these aspects of the management of dyspnea from a palliative care perspective. Thank you. Thanks. So total dyspnea is this concept that is talked about in the same vein that we hear about total pain. And so dyspnea itself is a very common symptom. And that's obviously why even, the same for Melanie talking about nausea and vomiting. Dyspnea, we felt that was an important topic to discuss because of how frequently it is seen. So more than half of the patients with advanced cancer will experience it. And most people who are imminently dying within hours or days of their death, they will experience it. It's a subjective symptom. So unlike vomiting, where we can see it, we can measure it, shortness of breath is like pain. It is difficult to measure other than the all-important history that the patient provides us. The subjective nature of it also, though, very importantly, is influenced by a number of factors. And this is where this concept of total dyspnea really becomes very apparent. So yes, it may have physiological causes, but also the psychological background for the patient, what their social situation is, and where they live, how they live, what their home is like, or what the hospital room is like, will also influence it. Even though we see this in more than half of our advanced cancer patients, there may not actually be a localized cause. And in particular, 1/4 of patients will not actually have any cardiac or lung disease. It's also very commonly associated with another symptom, that being anxiety. Thank you. So when I look at the management of, if I'm asked to see a patient with significant dyspnea, where the other doctors are requesting some support, obviously, as always, with every consultation, particularly in palliative care, establishing rapport, building the trust of the patient is the first thing that I try to concentrate on. Specifically with shortness of breath, I will then really be wanting to try to understand how severe the symptom is. In particular, whether it is something that has built up gradually over time, has suddenly gotten worse, is it present at rest, or is it only on movement? Because a lot of that will help guide the management. The holistic assessment of the patient, so looking at the whole person rather than just looking at the disease, is important, and that comes back to what I was mentioning before about the concept of total dyspnea. So looking at these other components. I always will also just want to double check that the other doctors that have been looking after the patient have not missed any other possible causes. We're doctors, nurses, we're pharmacists, allied health, we're all human, we all make mistakes, we all miss things. And I think that even in the hospital where I mainly work with, where the patients are under the care of another specialist, there will regularly be a situation several times a year where something might be missed. It could be a pulmonary embolus, or there might be heart failure that hasn't been fully recognised in a person with actually lung cancer, those sorts of possibilities. So the reversible causes, I think we should always be reminding ourselves about looking for those. The goals of care are really very essential because of the close association between dyspnea with two things. One is that there can be a reversible cause, and secondly, the fact that it is, as mentioned in the previous slide, it does increase in prevalence the closer the patient is to death. So I want to get an understanding from the patient and their family as well. What do they want in terms of the treatment of that shortness of breath? Do they want us to drain a pleural effusion, do a scan and start them on anticoagulation? Or are they actually saying, just manage my symptom, let me go at home? If it's a chest infection, do they want that pneumonia treated with intravenous antibiotics, or would they just like it treated just with oral antibiotics alone, for example? We've all lived through the experience of COVID as well. So that's, I think we all understand how goals of care can be relevant for that. But despite what the etiology, the cause of the shortness of breath might be, what's the overall prognosis of their condition as well? Thank you. So coming then back to this case that I mentioned, so this was a 79-year-old lady, and she had long-standing chronic obstructive pulmonary disease. As she'd previously been a smoker, but it had been quite a number of years that she had stopped smoking. And so she was referred to us when she had been admitted to hospital with an exacerbation in her COPD. And her main two symptoms really at that initial review were shortness of breath on minimal exertion. And when I say that, really just talking to me, she had to take breaths during the conversation, and even just moving from the bed to the chair next to her was the limit of what she was able to do before she would get short of breath. And related to that was anorexia. So her spirometry showed that her FEV1 was less than a litre, so clearly she's not an athlete by any stretch of the imagination. So about 1/4 of what she would have been expected to have. She was under the care of the respiratory team. They were doing everything appropriate. It had previously been well tested that her shortness of breath did not respond to steroids. Thank you. So she was, so in terms of a holistic assessment, she was a widow. She lived alone. She did have a son and daughter, and she was particularly close to her daughter. She said that her son wasn't coping with her severe illness, but they lived nearby and they were a support. She was very, very independent, and she let you know that she was the boss. Even she was the boss of her local sporting team. So here in Australia, we've got a very popular game called lawn bowls, and it's very, very popular, particularly with elderly people, because it doesn't take a lot of energy to play. We joke about it that it's the sport in Australia with the highest mortality. But that's not because it's a dangerous sport, but just because people are very old when they tend to play it. And she was the president of the club, the captain of the team, and she couldn't play anymore. So it was the shortness of breath had taken away a major part of her identity. And she was frustrated. But she said, "No, I'm not depressed." Thank you. So on examination, she was, I think, as we would be all used to seeing, she was cachectic. She'd lost a lot of weight. She could still talk in full sentences, but by the end of a full sentence or several sentences, she would often just need to pause. She didn't look depressed. She didn't sound depressed. She didn't cry. She was just angry, frustrated, and she was not hypoxic. So she was not on oxygen. Thank you. And her chest X-ray was, I think we've seen this many times, it was exactly as we would expect. So hyperinflated, blunting of the costophrenic angles, and a very stretched, elongated cardiac silhouette. Thank you. So we then... our team, we went through just our standard approach. So we wanted to understand what her goals of care were, what measures we would want to undertake for investigation or treating reversible causes, and explaining to the patient as well as the family, because especially for the loved ones, they will want to understand other components and their input, particularly with the associated symptom, which I mentioned earlier on, how common anxiety is. The role of the family in a dyspneic patient can be very important. And thirdly, I'll always want to remember that no man is an island, so I don't operate as a solo palliative care team. I work in a team, and so I rely on the nurses that I work with, the priest that I work with, the social worker, the occupational therapist, the physiotherapist, just to get their support in looking and addressing these things, just to make sure, obviously, that I don't miss things, but also we know that patients will open up to different staff members in different ways. Thank you. So the first component in our management is definitely opioids, and they do work. So we need to educate patients that morphine is not just for pain, but it can be used for shortness of breath. So if we want to be somewhat technical about it, opioids improve our ventilatory efficiency. They adjust our response to hypoxia and hypercapnia. They affect our drive to breathe, and they relax bronchoconstricted airways. But ultimately, what they do is that they reduce the distress that a person will experience from the sensation of shortness of breath. They've been extensively studied in the setting of dyspnea, and there is very good evidence that they work when given either in the oral route or by injection. Many years ago, there was a lot of prescription of nebulized morphine, but that has fallen out of favour due to the studies that have demonstrated that it really does not work as well as even just a nebulized saline, and certainly not as well as oral or injectable opioids, and it can be associated with bronchospasm. Increasingly, and there are really very good studies that have come from the east part of Australia looking at this, is that the best evidence for morphine is actually in low doses. High doses are not necessarily required if the patient is opioid naive, meaning if they're not already on opioids for other reasons. But if they are for pain, for example, then it may be reasonable to make a small increase, maybe even just a 25% or so increase in their opioid dose to assist with that symptom. Thank you. So there are a number of features that may actually tell us that this person is more likely to respond to opioids, to morphine. So particularly if it is associated with, if the patient is fearful or anxious, or they have panicking episodes. I should have actually mentioned as the first point here, that I actually do primarily restrict my opioid prescribing to people who are short of breath at rest as well. So if they have shorter breath only on exertion, then I will more talk about some of the other measures, in particular the non-pharmacological measures. Second component where it may indicate, and this is from previous studies that have been done, is that if the patient is saying, yeah, this is actually getting steadily worse for me, that they've tried pacing. So they've tried just doing their day-to-day activities in a slow and steady fashion. They've already tried reducing their activity levels, and that hasn't worked. They've tried behavioural techniques, so maybe relaxation breathing, for example. And also, if it is unpredictable in onset, so they will say, Anil, just for some reason, I don't know, suddenly I just get short of breath just out of the blue. Thank you. So the big challenge with opioids, as we all know, and we've all been taught this, is that they cause respiratory depression and death, don't they? And so anyone who prescribes morphine to someone with chronic lung disease, they should go back to medical school. So that's not actually the case, and there have been a lot of studies now that have shown that, yes, it does affect our breathing, but it will actually, and this is the important proviso here, is that this is only in the doses that I've been talking about, and with careful monitoring, that if you prescribe it carefully, then it can be done without actually causing hypoxia or raised CO2 levels. Yes, the respiratory rate will be affected, however, but again, we're prescribing it carefully. And so here, I think that, and this is, I think, one thing that I have learnt the hard way, both in the work that I've done here in Australia, but also in particular when I have done work in India, is trying to provide that reassurance and give the education to the doctors that I'm working alongside with, that actually we're not trying to do anything dangerous or silly, but this is evidence-based practice. Having said that, patients with COPD will be, because they're often maybe their physiology is different, but they're often less accepting of the opioid side effects. And so the dose that we might start with may be a lot lower than what we would start in a person with pain. So it may even be, I will commonly now, and I think that this is something that I've learned over time, is just that maybe many years ago, I was using higher doses, maybe starting at 3 or 4 or 5 milligrams, but now I will commonly, especially in a COPD patient, will regularly only start with a 1 milligram dose. Thank you. So this is confession time. This is I first met this lady a number of years ago, and I learnt the hard way that I was prescribing too high a dose. So I actually prescribed her a 10 milligrams slow release dose that would last the full 24-hour period, and that was too much for her. She became drowsy, and so we had to stop it very quickly. And fortunately, no harm resulted. And so instead, but she still was happy to, and she still fortunately trusted me, that we agreed just to go back just to immediate release morphine only. So 1 milligram at a time, and maybe up to 4 times per day. And my instruction was to her was that use it primarily when you feel the shortness of breath is worse and you're not really managing, and you've already tried to rest and just sit quietly. Over the years that I actually looked after this lady for 3 years, and we only ever increased the dose up to 2 milligrams every 3 hours. So there wasn't a big increase in the dose. Thank you. So the second major component of our management in shortness of breath is the anxiolytics. So there are different anxiolytics, obviously. So the first class are the benzodiazepines. And so if we're talking about just pure shortness of breath, there is weak evidence of benefit and potentially significant risks with drowsiness and also respiratory depression. It's really very, very hard for many patients, or when I'm seeing patients, is to sometimes separate out the shortness of breath that they're experiencing and the anxiety and panic that they have. And so sometimes they're so combined together, it's difficult to work out. And so just going through it in a cautious fashion and not making too many changes with the medicines at once. So my current, and I think that you can already gather based on what I had already said about my morphine prescribing, is that my prescribing has changed over time. So previously I actually used to use and prescribe mirtazapine first line. But actually now I mainly start with escitalopram, which is an SSRI, which unfortunately I did not see on your list of essential medications, but sertraline is on your list. And so that may be an appropriate initial medication to trial in an anxious patient with significant dyspnea. Thank you. So with this patient that I was looking after, she steadfastly initially said, "I'm not anxious and I'm not going to consider it." But fortunately, I wasn't working alone. She had a general practitioner, her family doctor, and we both really agreed that this was an issue. Yeah, as mentioned, it was a number of years ago, and so we both agreed that mirtazapine was a reasonable first choice. Just 1 dose, and she did not tolerate it. She felt very, very unwell, and she threw them in the bin. But interestingly, because her anxiety was so significant, as the months passed, she did say, "Anil, this is a problem. I can see that it's a problem." And then we agreed to try it again. And interestingly, she responded very well without side effects. And she herself admitted that it did help her. Thank you. So the third treatment option is oxygen. So the first point is, and I think that we may already be familiar with this concept, that you can be short of breath because it's a subjective symptom that people are experiencing. You can have dyspnea even with normal oxygen levels. Because of that, the other factors, it's not just a physiological problem. And then potentially you could also have no shortness of breath, even though you're hypoxic. The most evidence for oxygen therapy is obviously in the COPD population if they are hypoxic. So if their partial pressure of oxygen is less than 55 or less than 60 if they have secondary heart dysfunction, cor pulmonale. But a number of studies have really not shown that oxygen is beneficial in either cancer or non-cancer patients if they are not hypoxic. There is always this question, though, that when we look at these studies, and research in palliative care is very challenging, that maybe there are limitations to some of those studies. And I think that I would have to confess that in some patients, I definitely will give a trial of oxygen therapy, even if they are not hypoxic. If I've really tried opioids as well as anxiolytics and non-pharmacological measures. But if you're looking at, well, how does oxygen compare with opioids? Then yes, the most benefit is seen with opioids. Thank you. So interestingly, and it was good doing this, preparing for this presentation, because it gave me a chance to review some of the literature, is that yes, there have been studies looking at just medical air. And it does seem that this may, and the word of importance is may, improve quality of life and shortness of breath for some patients. And probably it's seen, and there are significant limitations, but it's patients with dyspnea that is not as severe. So if the severity of their shortness of breath is much higher, then oxygen is probably better than medical air. Most of the benefit is seen earlier on, and it doesn't seem to vary according to the underlying problem, the underlying diagnosis. Thank you. So my patient, she was on a mission and she said, I want oxygen. And her respiratory physician was very much of the view that she was not hypoxic, and so therefore I am not allowed to. The rules here in Australia are strict, and I'm not allowed to prescribe oxygen, and so I'm not going to. The rules here in Australia are a little bit different in that potentially if we, from a palliative care perspective, if certain criteria are met, it is possible to prescribe oxygen. So I did prescribe it for her because I felt that she was at significant risk of dying really within a number of months. And the limit of how far she could walk at this time that I did eventually prescribe it, this was several months after I first met her, she could only walk really 5 meters. So really just from her bedroom to the toilet. Thank you. So sorry, just the final thing to say there is I prescribed it and she felt subjectively better. It is worth mentioning, though, that the disadvantage with prescribing oxygen in this setting is that then it can become a potential psychological crutch for that patient, that they feel that they can never manage without it. It is definitely expensive. And frankly, it's also, it's got its own set of problems. And so it's something that they need to be constantly mindful of where they are dragging the oxygen tubings around. I think Melanie would probably be like me and have seen patients who've tripped over their oxygen tubing and have fractured their hips, which is terrible. And it's obviously not something that is, ever nice to see. So then final component of management that I wanted to mention are the non-pharmacological measures. So handheld battery-operated fans are available for purchase here, and they're really very, very helpful. But even it doesn't have to be a handheld fan. Often just having a fan in the room where the patient is spending most of their time. Ideally, the airflow needs to be on the face. And so an interesting study actually compared having a handheld fan and pointing it at your face versus a handheld fan and pointing it at your leg. And there was a benefit in the benefit was seen if you pointed it towards your face. Walking aids, that I think is very self-evident, it's obvious. So do they need a walking stick, a walking frame, a wheeled walker, or even a wheelchair? So by this stage, my patient was definitely using a wheelchair for any movement outside of the house. Breathing training. And so many patients will actually learn this themselves just through perhaps, I'm not sure what words I'm looking for, but their body just teaches it themselves. And so many COPD patients will learn pursed lip breathing, where you increase your expiratory pressure. But if you see a patient with dyspnea and they have, I think it's a worthwhile technique to mention to the dyspneic patient, because one of the things that it does, especially if a person is experiencing episodes of severe dyspnea, is that it's a good way of actually helping them to relax and concentrate on something. And so it's almost like here in Australia, it's very popular, this term of mindfulness. And so pursed lip breathing is almost, I think, in a way, a form of mindfulness. And so instead of thinking about my lungs and panicking, all I do is concentrate on what my lips are doing. And so starting with your lips just very gently closed and then pushing the air on expiration through the lips. And then that way, then the patient will concentrate on their breathing, concentrate on their lips. Sorry, not concentrate on their breathing, but concentrate on their lips and hopefully slow themselves down. Pulmonary rehabilitation is really, certainly in the patients that I see, is mainly restricted earlier to in their disease course before they are referred to palliative care. So just exercise training and learning to manage their exercise tolerance. But the other non-pharmacological measures are the procedures. So pleural effusion drainage or bronchoscopies can sometimes be of benefit. And so definitely the important component with the pleural effusion drainage is really just trying to work out the patient's prognosis and what their goals of care are. Do they actually want an intervention that is invasive? Thank you. And so my patient, she actually had a treatment that I had never come across previously. And so that was what's called endobronchial valves. So I certainly don't expect that would necessarily be available in Bhutan, but these are valves that actually that are placed within the in the bronchi. And in her case, she had two, one on each side in just particular smaller airways that allow air and mucus to leave that component of lung, but the air cannot re-enter. And so it results in collapse of the distal part where that valve is placed. And so hopefully in effect, it's a form of lung volume reduction given the hyperexpansion. She tried it, it did not help, and so they were removed. She was referred to the cardiothoracic surgery team for consideration of lung volumes reduction surgery. She met with the surgeon, but when she heard about the potential risks, she did not want to expose herself to those risks. Thank you. So as you manage a patient with dyspnea, then we need to think about, well, what's our long-term plan? So we need to go through these various components. So the pharmacological management, so opioids and anxiety, an in-depth psychological assessment. So that obviously really requires a lot of trust between you and the patient. The non-pharmacological therapies, and really then the two final points, monitoring the deterioration, because patients will often actually, they may not directly or quickly ask, they may want to know though how long they have left to live, but also then planning for when they deteriorate. Thank you. And so in this particular case, it was interesting that initially she wanted life-prolonging treatments. She said, if I get a chest infection or if something bad happens, I want to come back into hospital. But a year after I first met her, she actually changed her mind and she said, I don't want to come into hospital. I don't want any antibiotics for a chest infection. I definitely don't want to be going to ICU. All I want is that if I get bad, take me to hospital and give me medicine so that I can die in peace. Interestingly, she survived for 2 more years after she made that decision. So that was definitely a lot longer than I thought, but in that time, she had palliative care management only. So that's all that I had to say. Thank you very much for your time, and hopefully it was some help. Over to you, Tara.
Thank you, Anil. Thank you very much for your comprehensive presentations. And I think the final point that you mentioned, that even if you expected the patient to die sooner, palliative care actually extended that longevity, and it does extend. And yeah, so many things that I personally grasped from your presentation. I'm wondering whether our participants have any questions, although they haven't mentioned anything on the chat box. If there's anything on dyspnea or nausea and vomiting, maybe we would do some discussion here at this point before we go to case presentation. And I think one thing Anil did mention was about the confession that you made about what didn't go well in the practice, because I think not many confesses that. And also for us in our audience, to our audience here, I think it is really helpful, because as we begin palliative care, as we begin to take care of it, and we are still not very confident and not very comfortable in using especially opioids, and more so in respiratory distress, So even if when you had used 10 milligrams, today you go with 1 milligram to 2 milligrams. So there's so much to learn from there. And we do see many dyspneic patients with lung disease, but also with other comorbidities. So yes, Anil, you had a question. Did you have anything to say?
Yes, this actually was a question to Melanie. What do you do for patients with Parkinson's disease who have nausea, and you might want to prescribe either metoclopramide or haloperidol?
Yeah, great question. Thank you very much. Because of the extrapyramidal side effects, we avoid those medications in Parkinson's disease. So we would use an antihistamine, probably. A cyclozine would be the more common agent we would use in Parkinson's disease. The other thing, we can use domperidone because it doesn't cross the blood-brain barrier, but not available in Bhutan.
Thank you.
Thank you. I think I missed that question, but great question. And if there is no more question for now, I think we will go to case presentation, and maybe then we will have more points to discuss after listening to the case presentation. So over to you, Dr. Kinley.
Thank you so much,
Thank you,
Tara, for your kind introduction, and Dr. Anil and Prof. Melanie for your splendid presentation and a very detailed lecture. I felt like I was back in my training. Thank you so much for all the fresh memories. Okay, maybe for the audience, after I present, maybe the lectures will become more clearer. Okay. Am I clear and audible?
Yes, yes, you are clear and audible. Yeah.
Thank you. Okay. Is my screen visible?
Screen is visible
No.
totally, including your computer screen actually.
Oh, okay. Yeah. Just give me 1 second. So yeah, as Dr. Tara mentioned, I just recently got back from my training. It's just been more than 2 months. I managed the OPD patients, and then as the junior doctors, they managed the ward. So this patient was, I was actually called in to see this young gentleman. So, okay, can you see my full slide?
Not yet. No, not yet.
Oh, it's visible on mine. Is
No,
something
we
wrong?
still see your whole the desktop screen, I think.
Okay, I'll share again. So sorry for the
No
glitches.
problem.
Is it visible now?
Not yet. Yeah. Yes, it is visible.
Okay. So yes. So the case I brought up for discussion today is a young gentleman, 32 years old, much younger than myself also. So he's a diagnosed case of advanced rectal cancer on palliative care by patient choice. The site of disease is in the rectum, anal region, and peritoneum. The disease is also further complicated by severe anemia, which is secondary to the bleeding from the huge fungating rectal tumor, which required repeated blood transfusions for many, many months. And he also has a grade 4 pressure injury from immobility. It's further complicated by vesicorectal fistula, for which he has a diversion colostomy and suprapubic catheter. He also has a very severe grade 3 bilateral knee contracture, which is secondary to the immobility, which claims to be due to poorly controlled pain. And I feel very bad because it's like we are responsible for this problem. And his function, he's ECOG 4 since July 2023. So as I mentioned before, I don't look after the ward. So the patient was actually admitted on 13th of October with the severe signs symptoms of anemia, almost in hypovolemic shock. He was picked up by ambulance when he experienced some SOB, shortness of breath on minimal exertion. And at that time, he had syncope and family had to call ambulance. On his arrival to emergency, the HB was found to be 2.6. He was paper white pale, so 2 to 3 pins of PRC was packed. Red cells were transfused, and he was stabilized and subsequently admitted to ward for. By the time I saw him, it was almost over a month. At the time, he was being managed for his pain as a mixed nociceptive and I think neuropathic pain from the tumor, as well as the grade 4 pressure injury. And for this topic exactly, since we are talking more about other symptoms in palliative care, I wanted to concentrate on nausea and vomiting. So at the time when I saw this patient on 23rd of November, he was complaining of nausea on and off for 3 days. He was already admitted in our ward, and he also has this vomiting, which was his nausea was followed by vomiting for the same duration of 2 to 3 days. The vomitus, the content was food particles in water. It was non-villous, non-bloody. It was also associated with some intermittent colicky pain. However, he doesn't have any fever. No headache, no fever to suggest any features of infection, which will also lead to nausea, vomiting. And there was no headache also, which we might think of brain metastasis or ICP raised, but there's no known metastasis like 6 months before. And he also has no bowel opening for last 5 days, prior to my examination. So if we look at the history of his illness, he was first diagnosed in early 2021 during COVID pandemic lockdown, when he noticed that he was passing a pencil-thin stools associated with blood stains sometimes, prior to experiencing a very sharp shooting pain in the anal region, which actually made him seek medical attention. But since he was very young and young male going to ER, he was always sent back after injectable analgesics that lasted for almost 1 to 2 months. Finally, he decided that nothing was happening to him, so he went to a private clinic where our senior surgeon there offered him a digital rectal examination, found the rectal which was easily bleeding on touch. So considering his age, and also he was severely in pain, he was quickly referred to surgeons at JDW-NRH who helped to expedite the diagnosis with tissue diagnosis. At the time, it showed a moderately differentiated adenocarcinoma, and on the CT scan of the whole abdomen just showed a segmental mass in the rectal region, and since it was a locally advanced cancer, he was offered new adjuvant chemotherapy in June 2021. So after more than 30 days, like a month later, he was already seems to be in his second cycle of a chemo, in the first line chemo. However, he developed severe side effects from chemotherapy, that is nausea and vomiting. And then, yes, he lost faith in treatment. He lost trust in all the healthcare professionals, and he was lost for follow-up. Exactly more than 2 years later, he presented to same emergency room with several episodes of vomiting 2 to 3 days prior to presenting at emergency. There was also no bowel opening for same duration, and at that time the CT scan showed there was peritonitis from the obstructed intestinal obstruction, and there was a tumor metastasis in the peritoneum, and then he underwent laparotomy that time. Yes, so that's the history of presenting illness. And as we know, as I mentioned in the earlier slide, that he was actually admitted to our Paro hospital due to signs and symptoms of severe anemia. So again, you can see that there's gap of almost 3 to 4 months in between, but he was a regular visitor of our outpatient department, where he had received blood transfusions every 2 to 3 weeks. So on examination, he was lying supine with a flat pillow. He was very cachectic. However, he didn't look toxic. He was oriented. His pupils were reactive and bilateral. He reactive bilaterally and 3 millimeter. The reason I'm mentioning all this, the respiratory rate and pupil size, is also because he was on a very long-term morphine tablets. His abdomen was soft, bowel sound was present. His colostomy bag was, you can see, a very small paddock-like stools, and there was a huge sacral wound which connects with a huge fungating tumor in severe bilateral knee contracture and pressure sore. And there was also this foul-smelling mucus discharge at the anal opening in breast, for the picture which might pop up. Just to caution if you are not so used to seeing very fungating wounds. So this is the back of my patient, 32-year-old gentleman. This is after almost a month taking care of his wounds and pain. So this is the fungating wound and the pressure sore, which has healed with best support from my nurses at the ward, and also with the effort from physiotherapy, who helped him, move a bit on his bed. So treatment and significant investigations. Actually, I think I didn't really see the significant investigations. I was just focused on treatment. So he had 2 cycles of the first line of chemotherapy. I really don't remember what he was given, but he mentioned that he had a very severe nausea, vomiting from it, and he stopped it on his own. He didn't go back to his doctor until July 2023, when he actually went into peritonitis from the obstruction. So it's in 2023 that he has a small bowel obstruction and a burst, due to which he has to undergo laparotomy with cholesterol. And he also has this vesicorectal fistula, to which he has diversion SPC. Okay, so if we go at the psychosocial aspect, actually, I really had to pace with this gentleman. He's very young, very stoic person, very, very independent. So, I really had to pace with this gentleman, and it really took a lot of my time to build rapport with him. He actually opened almost after 10 to 14 days when I was with him. It was really difficult for me to gain his trust. So I actually first started with managing his pain. So when his pain was relieved, then I started gaining his trust. So that's when he was explaining about all his disease journey and his frustrations and everything. So the reason actually I was consulted for this patient by my colleague was that, oh, we have a morphine addict patient in the ward. So that was when they actually wanted me to see him. So on his discharge, he was sent home with a sustained release morphine 15 mg BD and immediate release 10 mg morphine SOS. So he was taking this SOS dose 6 to 7 times a day for his pain. So you can imagine a young man was severely in pain, and it was really difficult for me to gain his trust. So it really took a long time and effort, and a collaborative effort from the whole hospital, the nurses, even the CMO, everything, because we have to mobilize the injectable morphines, which is not available at the district level. So yeah, so he's the youngest of 5 siblings. He's married for 3 years with a very young child. He has a 2-year-old son. His father died of some medical condition some years back. His mother is 60 years old, still functioning, but lives with eldest sister. His all siblings live apart and they are away, not in Paro. They only visit it often. So this young man is actually a manager at a private company, who pays him very handsomely, but he has not been able to work since July. So he is solely surviving on his wife, who also works in a private company. And she has a very odd working hours that, she works at private company. It's actually in the airline, so she has sometimes had to leave by 3 a.m. And then this patient is so though he's very independent and like he's very strong, he always needs his wife by his side when there's some need for cleaning his dress or dressing, or to change his diaper. He always needs his wife. So it was very stressful for the wife, and also the wife is main bread earner. So there was so much psychosocial aspect in here. So like I said, this gentleman is a devout Buddhism. So the main reason he actually lost faith in healthcare professionals and the treatment we're offering is because he was seeking traditional treatments, and he was with his root lama following all the prayers and everything. So he's a devout Buddhism. His content is what life. He claims that he cannot change what God had planned for him, and he seeks solace in his root lama. He doesn't really pray, but he listens to his prayer daily. He has a small radio by his bedside, and his family also comes and prays for him. And like I mentioned, like he mentions that he cannot change what God has for him, but at the same time, he also shares a lot of frustrations and grievances, towards healthcare professionals. So it was really sad to hear such a young man sharing so much frustrations towards the healthcare system, when we on the other side are doing our best to give our best service to our patients. So this was something I really wanted to reflect on too. Yeah. So his hobbies, he likes playing soccer games, and his only worry is being in pain. So I think I did the right thing, that by helping him control his pain, that I could really gain his trust, and I was able to help him further. But there was also many more challenges that I wish that I could have done better for this young man and his family. And he also worries about leaving behind his young son and wife, and he has so much financial concerns. As I mentioned before, his wife is the sole bread earner, and he's so afraid of dying in pain. So So that's one reason that as I will share the medication I will use, I'll maybe explain that time. And the frustrations, he blames healthcare professionals for late diagnosis. As I mentioned before, he was sent out from emergency for almost 2 months, just giving the injectable analgesics and not giving a proper examinations. I'm not sure what happened on the other end because there is no medical records that I can see, but that is solely from his sharing. And he also blames the healthcare professionals for not giving him proper informations. He points out at being missing out for defaulting his chemotherapy, as he wasn't really told about everything about the chemotherapy, and then which led him to discontinue the treatment and resulted in everything that was following his life. Yes, and also inadequate pain management. I totally feel that the healthcare professionals, when we're managing the symptom, we must manage it, adequately, so that it will not result in any untoward consequences for this patient. Because of the inadequate pain management, he was not moving from his bed at all, so which has also resulted in a pressure injury and the severe contracture in his bilateral knees. So at this point of time, just to recall a little bit, when I saw him, this patient has nausea and vomiting for several days. And when I checked his medicine, he was on morphine, sustained release 15 mg, 12 hourly, and immediate release 10 mg morphine. He was taking like 6 to 7 tablets a day. Every time when he was having severe pain, he was taking 1 tablet. And because as you know that even the immediate release morphine, it takes around 30 minutes for the onset. So he was taking another dose. So that's why there were so many medicines being taken. So, and then when I checked on his laxatives, he was not adequately prescribed with the laxatives, and also he was not really educated well on the side effects of the opioids. So that has resulted in his constipation and then in the nausea, vomiting. So I gave the glycerin suppository at his stoma, and I was very careful in giving the metoclopramide, considering his peritoneal metastasis. I was, as we know, the metoclopramide is a prokinetic. I was being very careful to push it too hard also, because it might result in peritonitis. But it was very lucky that I gave 1 dose, and after the stoma increasing the lactulose, he actually had a good bowel movement, and then his symptom actually subsided within a day or 2. So this simple thing that we can do in every district hospitals. And then I had to change all his medication. So I kept his morphine as a sustained release 15 mg 12 hourly as it is. And because he was having all this incidental pain, so I had changed the immediate morphine release into, after much calculation, as we have, if you can recollect from the previous week's lecture, I think it's by Prof. Melanie, the MEDD for morphine, and also his MEDD comes to around 75. With the reason I was keeping this morphine like 12 hourly and then every 4 hours because of his incidental pain, it was best managed with this one. And then because he has a very high incidental pain from the fungating tumor. Whenever there's a rectal, the mucus discharge being spilled over his pressure sore and fungating wound, there was a very severe incidental pain which goes up to 8 to 9 out of 10, and which lasts for any very short duration. So with the MEDD, and I was taught to use 1/12 for IV. The reason I use IV route is because he needs a very immediate relief, and then the pain is very incident and is very high level, so I wanted to quickly relieve the pain. So the reason was that I gave him IV morphine 6 mg. So by calculation of MEDD, it comes to 75 milligram in 24 hours, and 1/12 of that is actually comes to 6.25. But to be easier with the nurses, so I just gave it like 6 mg. So with this, from 6 to 7 breakthrough morphines, tablet morphines, he required only 2 to 3 doses in 24 hours. So it was very, his pain was actually well taken care of. And with the regular regular senna and lactulose. His constipation also well taken care of, and subsequently his nausea and vomiting also disappeared. Yes. And the other medicines, amitriptyline and lorazepam, I started them for his poor sleep, but lorazepam was also not available, so it's just on the chart. So the main concern for this patient, the young man, was the poorly managed pain, which resulted the patient and family members to be very frustrated. For him, there is a baseline pain score of 4 out of 10, and incidental pain, as I just shared, 8 to 9 out of the 10. Yes, and there was a poor bowel care as he was on a long-term morphine, but patient was not compliant to laxatives. Reason I just derived as maybe it's inadequate information and education to patient and family. So for this particular case, it was the main reason for his nausea and vomiting. And psychosocial support, I did seek help of our counselors to really motivate this gentleman, but I'm not really sure how much our counselors are well aware of the palliative care psychosocial support. We don't have medical social workers in the country, so I was getting help from the counselors. And also, we don't, though he's a very devout Buddhism, we don't have a religious heads or other lamas or anybody who can help him in district hospitals, unlike the referral centers. And I was also thinking, like, since he had developed a severe knee contracture, but his upper arm was very good, so I was really needed. I could have used the occupational therapies or physiotherapies. My physiotherapist did try his best, but then it was really difficult because the damage was already too severe. So I also wanted, if the allied health workers could actually do him more help. So in summary, this is a 32 years old gentleman with advanced rectal cancer. You can see the site of disease in the rectum extending to the anal canal with the metastasis to peritoneum. His function is ECOG 4, that is bed bound. He's completely bed bound. He cannot self-care. He can only eat lying supine, nothing more than that. I did manage to kind of let him wash and brush his own face. He presented with severe mixed nociceptive and neuropathic pain from the tumor and pressure injuries, and the nausea and vomiting from constipation. Patient also had the pertinent existential distress, which needs multidisciplinary approach and management the best care for this young patient and his wife. Yes, so the discussion point I wanted to put up all the experts here is, our health staffs. Dr. Tara is doing a very good job in bringing this platform all over the country. So I think with the more this kind of talks and lectures, maybe our health staff will be more aware of it. So our health staff are not confident to give morphine, and we are not really aware, especially to tighten it up during the pain increase or to bring it down after treating the reversible causes, and if actually when the pain comes down. And the common causes of common symptoms and this management, as simple as this patient, the nausea vomiting was due to the constipation. And also awareness and knowledge of health staff to palliative care, and how effectively, I actually still wonder that how effectively could this patient symptom be managed with other allied health professionals. Like if we had occupational therapies or physiotherapies who have idea of a palliative care, or if we have a spiritual leaders, like medical social workers, could we have managed this patient differently and made it more comfortable for him. And this particular patient, I actually had challenges in bringing the injectable morphine because it was quite a short in supply in the whole country itself. But then this patient was really in pain, and so it was quite a challenging. So, in district, when I myself being someone who is working solely for palliative care facing this problem, I'm sure my colleagues in the district hospital will face lots of issues. So how we can, bring up, or we can, maybe bring up some solutions to maybe address some of these challenges. This young gentleman actually passed away last week at home. That's it. Thank you for your attention.
You, Dr. Kinley. Yet another very important case, and so much to reflect on there, actually. Given that we are running out of time, I hope we can discuss for at least 5 to 10 minutes. And in the interest of time, I think I will give the floor to Anil and Melanie to make comment on how you would have cared for having, a little understanding of our context here. How could we have done it, otherwise, because Kinley, as Dr. Kinley mentioned, she just got back after studying palliative care. Otherwise, as she mentioned, we would have labeled the patient as morphine addict or incooperative or, many other terms. So how would we have handled the case better?
Would you like to kick off, Anil?
You go, Melanie, first.
Okay. Wow, what a very, very challenging case. And I'd just like to say, what an extraordinary job you did managing him and gaining his trust after he had so completely lost trust in health professionals and the system. It's very difficult managing someone who's angry with you, and you did that extremely well and just very patiently earned his trust. And there's something there about bearing with his suffering, that you persisted and kept working with him to gradually gain his trust. So just want to acknowledge how difficult that is and what a very good job you did in managing that. I was interested in that kind of dichotomy, or the contrast between having faith in God's plan for him and anger at what the outcome for the as you noted. And I wonder, you so importantly raised there the need for spiritual leaders to be involved in these cases. We talked last week about total pain and how anger and distress and so on can increase the pain. He's got obviously terrible cause for his pain. It wouldn't be the only way of managing it, but it may make a big difference to his threshold to get spiritual leaders involved. So I don't know whether there's any possibility of getting outside practitioners into the hospital. That's what we do at our hospital. We don't actually employ, for instance, Buddhist spiritual leaders, but they come in when we need them. We have general pastoral care, but when we need something specific, so for instance, when we need a Catholic priest, we get the Catholic priest from outside to come and visit. The other thing I wanted to highlight there was the importance of the multidisciplinary team here. For you dealing with such a distressing case, it's hard to do that on your own, and to have someone to debrief with, to discuss the case with, to share the load is really important. This is a great example of how distressing these cases can be. So I just wanted to highlight the importance there of sharing, Dr. Kinley sharing with your nurses and others available to the counsellors and so on to share the load. In terms of that, the mucus discharge and it causing the direct pain. I'm interested to hear what you were doing in terms of dressings and so on. That is a very complex dressing because of its location, but dressings could potentially improve the comfort levels there. Sometimes, and I'm interested in Anil's experience, sometimes with very painful wounds, we from time to time use topical morphine mixed with Solugel, which can just reduce the requirement for systemic opioids. Occasionally we use lignocaine gel as well. In this case, I probably wouldn't, just because I think it would be uncomfortable and would cause stinging and so on. But there's that's a couple of thoughts. But you've got every class of drug that's important to be included there. I was just I think you've done a very, very good job in a very difficult case. He actually, given his degree of opioids, he's someone for whom obviously he's passed away now, but because you're getting to those high levels of opioids, he's someone for whom a fentanyl patch may be useful. Obviously, it would need supplementation with breakthrough morphine.
Yes, maybe I share. I tried to, because his incidental pain is very short-lived, like 30 minutes. I tried to give him with a fentanyl injection, but this man is fixated on morphine.
Yeah. That was what was going to work for him. Yeah. Lovely. Over to you, Anil.
Thanks, Melanie. Great presentation, Kenny. Very, very distressing, though, what he went through, and obviously, yes, how affecting it must have been for you and the team looking after such a young man with such an extreme wound. I'll restrict myself just to two comments. One was, well done on doing the simple things well. So looking at constipation, we all forget it. We all make this mistake, but well done for recognising that as a potential exacerbating factor for his symptoms. And secondly, well done for doing the maths. So the calculations, the doses of morphine can get very frightening and alarming. And so if we go back to our basic science and the conversions, and the titration to effect, that was also very well done, I thought.
Thank you, Anil.
Say one more thing. It's so sad when this man left after having severe side effects from the neoadjuvant chemotherapy. And so I think that sometimes, I think we can all be guilty of saying, oh, well, that's all right, he's out of sight, out of mind. But yes, with a multidisciplinary team explaining to him and his family what actually this treatment means, what the potential consequences of his actions are, things might have been very different, sadly, for him.
Thank you so much for the comment.
Yeah, thank you, Anil. Thank you, Melanie, and thank you, Kinley, once again. I know many of the participants here would agree and may be reminiscing their own, might have reminded of the cases that they have seen as well. And I think I personally really feel that so much of communication should have happened, and many a times we have our own challenges. We have very limited number of nurses, and time is one factor that is always a concern. But when the person was put on chemotherapy, I think so much of communication would have made a difference, I feel. And also that encouragement, so much actually does make a difference. But I think although we lost this patient in distress, I would feel, but so much to learn from there. And I was just putting in the chat that many such cases may be seen around the country, and when symptoms becomes difficult, out of sight and out of mind is not always the right approach. And so I was just suggesting that maybe hereafter although it may not be formally, but informally, I'm sure Dr. Kinley and Sister Youngden, the home care lead, would agree that let's work together and let's form a team. Let's discuss and do whatever we can in our own limited possibility. And if required, we would also seek out suggestions from people like Anil and Melanie and many others that I personally know. Kinley may know many others around the world. So with this session, I would really encourage everyone to come forward in discussing your cases and making a difference. So much to learn from this case. That's what I would say. And at least I was saying, patient at some point will accept the diagnosis. They say it's the God's will, but they will definitely not be able to accept the symptoms. It's unbearable, and so that's where they really need our help. And so let's do that. And really, I'm at least very happy Kinley's back. We really needed a doctor with a palliative care training, and we are growing. We are still at a very nascent stage, but we are growing. So thank you. And we are 10 minutes ahead. I mean, we crossed 10 minutes. So thank you, everyone. I always wish there's more time to discuss, but thank you, Anil. Thank you, Melanie. Thank you, Kinley. And thank you, all the participants. Let's keep learning more. And I hand it over to Sangeet now.
Thank you. Thank you, Dr. Anil and Melanie, for the wonderful presentations. Thank you, Dr. Kinley, for bringing up the case presentation. I hope every participants would bring case presentation on the upcoming session also, so that we can discuss about the patient stories, real life incidents that we can relate with our topics. Thank you everyone for participating. Thank you everyone for making it a really interactive section. Thank you. Let's see in the next session. Bye.
Thank you. All the best. Bye-bye.
Thank you and bye.